Extensor mechanism intact?
No, sir.
Clinically?
No, sir.
Not intact.
Yes. No, sir, it's not
So,
intact, sir.
so it's a complete avulsion of the
Ligament, patella ligaments.
What is it called?
Sleeve fracture.
Sleeve or sleeve fractures are common. Where else you get sleeve fractures?
Calcaneum, near calcaneal tuberosity avulsion fractures.
I told you this is important of sleeve fractures. That kind of clavicle.
Yes.
That's also common. I want to see this only. This plus that kind of clavicle, calcaneum. Wherever there is a apophysis or epiphysis, when they get traction on that, you get injury. It's called sleeve.
Sleeve fractures.
As if it's completely sleeve.
This is the introp picture. The distal fragment, bony fragment, is way too small to be fixed with TBW. So we have done suturing of patella tendon from distal to proximal with Lethivon through Krakow's suture technique, and we have
Magnified, good way. So what did you do?
we have debrided the wound, sir. We have removed any bone clots between the fracture fragments. Then from distal to proximal, we have sutured the patella ligament.
What is the ligament patella?
This is ligamentum.
Lower down, sit. Fragment is that which is very small.
This is fragments. So we have sutured the patella ligament from distal to proximal with ethibond through Krakow's technique, sir. And we have drilled 4 tunnels in the proximal fragment, and we have passed these sutures through these tunnels and tied with each other.
They don't have to this upper end of
Upper end of, but yes.
right? What are other methods to reinforce this?
Through circlage wire, inferiorly passing through tibial tuberosity.
How to reinforce this support? This will not hold it. Suppose complete flexion again disturb the
sutures are likely to give way. They are likely to get stretched.
how to reinforce?
No, however strong the bond may be, still it can give way. Any bone to bone stability.
We have to put a circlage wire, sir, through tunnel to tibial tuberosity. Here, otherwise we can, here, sir, tibial tuberosity.
Lower down upper end of tibia.
Yes, sir.
Pass it, I mean,
Pass a
screw,
yes,
make it anchor to that complete patella.
to upper pole of patella.
That's what the reinforcement of patella that is done. Otherwise it may not hold.
You can put it to K-wise also, because the fragment appears to be fairly big.
Next, flake.
Flake, huh? But in the dissection it shows post-op management.
Post,
Post-op. Making flex.
it depends upon
Here in the
introp.
case,
Here we have applied a knee immobilizer, sir, flexion up to 30 degrees, and we have allowed him,
he
yes,
will go
mobilization
and
of from pure.
knee brace, which is going to happen.
So what else did you advise? Strengthening?
Yes, sir, static quadriceps strengthening.
Otherwise you may have problem there. Suddenly flexing. What mechanism is injury here?
Sudden contraction of quadriceps on a flexed knee causes. This is the post-op exercise. Procedure is transosseous tunnel suturing of patella ligament.
As it become congruous,
Extra-articular.
is a non-articulate.
Extra-articular.
Is patella alta there or?
Pre-op patella alta was there, sir.
So that is higher up, right.
Almost
Mm, Yes, sir.
Tetra alpha is there, so we can
In fact, it is a very small plate. You can excise that and the suture enter.
Ligament.
It is a
make
very
it.
small plate.
No, nothing is there, it's very difficult to set. But you take a part of bone which is there, and easy to set.
Cracko sutures are very
Still,
firmly
the bony part
anchored.
is more tight. That's all.
No.
70-year female with intertrochanteric fracture of the right femur and 6 years old post-op case of intertrochanteric.
This is called petal of law. Most of the fracture petal, that's seen.
Stellate fractures. Comminuted stellate fractures.
Plates. That is one.
So if you're not there, now you got a petal of flax. Earlier there is only a TBW, TBW. Now you got the petal of plates and petal of claw. So many things are coming up. Newer generation. Star plates.
Closure reduction internal fixation with long PFNs.
Implant.
45-year male with 2-year 5 months old post-op case of middle third shaft fracture of the left femur with implant in situ. Implant removal was done.
20-year male with closed lateral canal femur fracture and lateral split tibial plateau fracture of right knee. This. It's a lateral condyle fracture. Yes. Part of it, sir. The osteochondral fractures.
Tetra is normal.
Yes, sir. This is a tibial split fracture.
Here also is reverse
Yes,
fracture.
fracture.
Okay. So both sides of the medial collateral ligament.
Lateral, sir. Lateral.
Sorry, lateral collateral.
What is fracture type there, tibia? Fracture?
Type 1. Type 1. We have done open reduction and internal fixation with screws, sir, with tibia and femur. And this is interference screw for tibia ka percutaneization, sir. Femur ka open చేసిన. There's a comminuted one, sir.
Three years male with closed intercondylar fracture of left femur, sir. It is a AO classification C2, sir, with the metaphyseal comminution, sir. We have done open reduction internal fixation with dual platings. Was done last week only. It's rare, sir. Rare, sir. Rare, sir, it was.
Identical fractures, both sides. Similar fractures. Is it possible to have?
Rare,
Find
sir.
out the article there? No. You didn't find out.
Rare, sir.
Now show both the limbs now. Both the limbs with the
We don't have X-rays.
other later.
Petalates, we didn't give.
No, same thing. Fractures are similar, surgery is similar, everything is similar. But you should know what exactly the type of violence. Is it possible to have some similar fractures? Depends on what impact of the technology, what the loss the patient had. You can have this.
Yes, sir.
Okay.
And right one,
Sir,
bike injury.
bike is a scar, sir.
Almost all.
Yes.
All the distal femur fractures are almost all bike injuries because the knees are directly exposed to the oncoming vehicles.
63 years.
Yes, sir.
Okay.
38-year female with closed middle third segmental shaft fracture of left clavicles.
Okay, all fractures to be now fixed.
So this is segmental and comminuted, sir. The three fragments.
So
This
not popping up badly. Okay, you are devascularizing the middle fragment, which is unlikely to heal.
To the post-op X-ray?
We are happy by looking at the X-rays only,
Yeah.
not knowing what is happening to all the clavicles.
You have done. Means some will come out, some have some problem.
Okay. We are fixing the clavicles injudiciously.
22 years, male with closed middle third shaft fracture of right humerus, sir. We have done open reduction internal fixation with plating, sir.
Why
DCP.
not conservative man?
What's the age?
22 years.
Best fracture.
Pressure.
No more fracture.
Just 2 weeks also.
Before that. So show that X-ray. Post-op X-ray. Pain on medial side. Compression baraale.
Sir. Yes, sir.
Compression baraale.
Which in the intra we can see the
Posterior aspect is the tension side for humerus.
You open that.
Humerus apparently looks like a straight bone, but it is never straight. It has got so many undulations where the plate may not get contour to the bone. So by looking at the reduction, you may have to bend the plate accordingly. But for middle third, probably posterior approach is better.
What numbers you have done?
sir.
Invariably, the
Antero-
plate goes on the anteromedial axis because that is the flat, nearly flat surface. We tend to put it always
On the
anteromedial,
Anteromedial.
almost medial, not anterior. See, it is on the medial side exactly. Anteromedial. That is the
Screws are
flat
sufficient?
surface.
Screws sufficient now? Still we had a chance of putting one above and one below.
Sir, as fracture extends to the sides, so we didn't keep it.
Fracture line is extending.
Yes, sir. So we didn't keep the screws near to the fractures. 65 years female with a closed trimalar fracture of left ankle, sir. It's a pronation, external rotation type of injury, sir.
Subluxation is there.
No, sir.
Posterior
Just
subluxation is there.
Fragment is big.
Huh?
This is
So looks very big. APView, it looks very innocuous.
lateral wireless. How much is it? So lateral wireless is
This one.
that is
This is the lateral. Posterior malleolus is not much. Probably the ligament must have been avulsed. Posterior tibioculum.
Yes.
Yes.
What is the mechanism of injury?
Pronation, external
This is
rotation type.
supination external rotation.
Supination external rotation
Bimalleolar fracture
with trimalar fracture.
with an avulsion and a compression on the
left side.
posterior subluxation. Typical supination external rotation.
Supination external rotation.
So there is a incongruity because of the tibiofibular ligament complex, syndesmosis ligament. It got subluxated. Okay.
So,
What is the other name for trimalar fracture?
cotton.
Cotton's fracture. Very good, sir. So
You have
supination
done-
external rotation. It's not pronation. Should be corrected.
We done open reduction internal fixation with plating for fibula and TBW for medial malleus, sir.
What is this group?
Malleus. Malleus.
Not running out like
Malleus screws.
malleolar. But it is not put in the malleolus.
But we have for tensions.
You can use a simple cortical screw. No need for malleolar screw.
What? Fragment is so big, there's no penalty at all. Just ask you hole and then through a tube will done.
Okay.
What is the indication
The
for
action is not
tension
vertical.
by using TBW
small fragments.
Sir, what is the indication of TBW for medial malus in your case?
Yes, it was too small, sir.
Huh?
To pass his screw.
Small.
Yes, sir.
Okay, why TBW?
K
You have
wire
passed some,
alone is
you have
not
passed some
enough.
of the wires also through the fracture, TBW.
K wire alone is not enough.
Sufficient.
The distraction force has to be converted into
Compressive forces.
Yes. Next.
3 years, 2 months old, both bone fracture, sir. With we had done implant removal, sir. Yes.
Nothing wrong with the bone or the brain got infection.
No, sir, no infection. As the growing bone,
How
we
are
have.
the bones post-operatively now?
So the plate imprint is there.
Yes.
Yes.
Can it break now?
Yes.
Suppose he wants to have full contact sports now. Can he do this?
No, sir.
Break.
Wait for 4 to 6 weeks.
Precarious.
What implant?
How old is that boy?
Semitubular, sir.
20.
Yes.
Age.
Sir,
30.
13 years.
13 years.
తర్వాత
There is a stress shielding effect below the plate.
Good morning, sir. This is a 38-year-old male with a closed middle third shaft fracture of left femur, sir. So it is a increased Hansen type 4. You have done closer direction till fixation with IL, sir.
3 mm distraction.
Yes, sir. Later on, we plan for dynamization, sir.
Create a problem, then do dynamization.
Sir?
Create a problem first.
We tried, sir.
Why can't you do immediately the infection?
Interoperatively, we tried, sir, but yes, sir.
Who is there?
Manoj sir was this, sir. Manoj, sir. Manoj, sir. Yes.
You can remove the second screw from the top
Yes, sir.
and make him bear weight after 3 weeks.
That's his fracture, yes, he can.
Yes, sir.
After the soft tissue heals.
Yes, sir. So 35-year-old male, sir, with 8-year-old post-op state follow-up case of middle third shaft fracture of right femur with implant in situ. Came for implant removal, sir. Sir.
8 years post-op.
Yes, sir.
He come after so many years.
He's complaining pain, sir, but he actually wanted himself to get removed.
Wanted to get
Yes.
next.
17-year-old female with 1 year 8 months old post-op follow-up case of closed middle third shaft fracture of right femur, sir, with implant in situ. We have done implant removal.
Mm.
24-year-old male with 4 months old closed middle third both bone shaft fracture of left leg. We have done ORIF with ILN for left fibula with bone grafts. Iliac crest.
What is the gap you created there? Distance is needed.
For reduction, we have done fibular osteotomy.
For distance, fibula to be removed.
Yes.
See the gap there between fibula.
Show the first X-ray.
You have put already graft, like this graft, right?
Yes.
But what you have done to the bone which is there, you have already thrown it out. Bone have removed fibula. They thrown. It was not yours. So we also need to do this much of fragment removed. Make it oblique hospital and leave it. If it's like, why don't you cut the bone?
It is already malunited, fibula is already
Yes, sir. Fibula malunited, sir. For,
so you are not getting the reduction.
yes, sir.
అంతే కదా? Malunited, you are not getting the reduction at the fracture site. But you have to get the alignment, reduction, displacement, rotation, everything you are correct. Lengthening, everything you are correct. Limb disturbance, otherwise you will get a limb disturbance. Yes or no?
Yes.
Okay.
Fibula is already malunited.
Next. Did you nibble the How is it sclerotic? Margins fracture.
Yes, sir.
Fragments are sclerotic.
We have nibbled. Yes, sir.
Is it not bleeding on nibbling?
No, not much.
Not bleeding. So you nibbled it till it has shown bleeding.
Yes, sir.
How much shortening is likely to be there?
Shortening.
Is there shortening or normal? Come to the other side.
Did you compare after the patient is shifted onto the trolley? Did you compare the limb length?
Not much shortening.
Yeah, compared or not? Obviously not. Have you checked?
No.
How did you say not much?
There is too much.
Don't bluff. Don't bluff.
So another thing is one more point. Any acute distraction more than 2 centimeters plus, it can affect the distal neurovascular deficit. That is also one point. At a time, acute distraction more than 2 centimeters. If it is more than 4 centimeters, 100% involved. That is also school of thought. You should be very, very important. When you plan for this old malunited fractures management.
Okay.
1-year-old post-op status follow-up case of cervicotrochanteric fracture of right femur, sir, with implant in situ, screw breakage. We have done implant removal and hemiarthroplasty for right hip joints.
What age?
50 years.
50 years. So you plan only for replacement only.
Yes.
50 years. What have you done?
I have done implant removal and hemiarthroplasty with AMPs.
What is the distal one?
Implant break.
Broken implants, sir.
Well, we are trying
PFN.
Still it is there inside.
to.
Yes, sir.
Broken implant is what? Process.
PFN.
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 Long-term process break అయినట్టు.
Process is the PFN.
అదే తెలుసు.
Go to the previous.
తెలిసిందిలే అయ్యా. Okay, next.
This is a 30-year-old male, sir, with closed fracture of first.
Screws are broken, I don't know. What is the postoperative period? Yes. Again he fell down somewhere or what?
There is no history of trauma.
Then how it break?
No, no.
Premature
1 year old
bleeding.
only, no?
Premature bleeding.
Maybe for such case what do you suppose? Child
He
here.
is an young man. He is not 50 years old.
What do you do? 16 years or 17 years, girl comes with a acid fracture, treated post-operative, this is what condition is. Screws are broken out, one inside the head.
Yeah, you have to open the joint, remove the screw, put a fibula graft.
You are open anyway.
Anyhow, already crack is made. Fibula struck. Use mechanical support.
What to do to avoid this breakage of implants? In children, always had to remove it within 6 months to 1 year, otherwise it breaks. The problem. The thing is, post-operatively not more than 6 months. See that infection. If it breaks, the problem for us. Implant removal is a problem, and then again we don't go. The best thing is follow it regularly. 6 months to 1 year, you have to take out the implant which is acid fractures inside.
But when once the fracture has healed, there is no
Yeah,
chance of
that
breakage.
comes out, right. That breaks, sir. That breaks it. Normally you get a
That means fracture has not united.
after the immuno, sir. If the breaks there, then problem comes for the immuno.
This is a 30-year-old male, sir, with closed fracture of first and second metacarpal base of right foot. His flank injury is a type B1, sir. Partially incongruity with towards the medial side. We have done CRF with K-wire fixation, sir.
Only medial column.
Yes, sir.
Lateral column is intact.
Yes, sir.
Fracture is this time.
Yes, sir.
What they want to put into the shaft only, not across the first and second uniform bone.
First and second is partially incongruity with medial side.
But is enough put only the K-wires into the shaft?
We try to reduce, but not reduce, so interrupt it.
First of all,
Yes, sir. No, sir, it was reduced, sir. It was congruent. It was congruent.
What's the angle between first and second? 7, 9. There? That's good?
Yes, sir.
That has to be
What
seen.
is the point of entry of KY?
From head to base, sir.
There. Dorsal, plantar.
On the plantar side. Plantar side.
How to put from plantar? Unless you hyperextend the toes, you will not get anything else.
Sir.
Hyperextend completely toes, go from the plantar side, get into this. Otherwise, no, not from dorsal side.
Cannot pass from dorsal side. When will you remove the KY?
No, sir. After 4 weeks, 4 to 6 weeks.
Sir, there is one school of thought. For the medial malleolar fracture, small fragment, the principles of TBW, some schools say 6 months, some people say it won't last. What is your suggestion?
Good morning, sir. These are the case done in Unit 2. Sir. 18 years male with closed middle third shaft fracture of right femur.
Medial malleus, greater tubercle, or something different.
18 years male, sir. Closed middle third shaft fracture of right femur. Unquestioned answer and type 3, sir. Yes, sir. So done interlocking nail for right femur, sir. Yes, sir. Yes, sir. Yes, sir.
Beyond 19 years.
Interlocking nail for right femur, sir.
Where's the entry?
Piriformis fossa, sir. Just
Safe. It's safe for children? Not safe for children. Is it safe for children to go through piriformis?
Yes.
This is good.
piriformis fossa.
It's good.
Good morning, sir. Sir, one case for discussion, sir. 44-year male, sir, came with complaint of pain and swelling in the right elbow since 3 weeks, sir. History of trauma, fall from bike, and history of native treatment 6 to 7 times, sir. In
Straight away put the X-ray picture. Because clinical presentation, you may not get much information except that he came with a limitation of movements of right elbow, post-injury, had repeated massaging
yes,
several times.
this is the
30 degrees FFD, 30 or something, 10 degrees. And flexion possible up to 30.
30 degrees.
From, from 10 degrees of FFD up to 80. 10 to 80. Pronation, supination, normal.
Yes, sir.
That's all, that much information is enough. X-ray will tell the entire story.
This is the X-ray after injury, sir, and this is the X-ray after 3 weeks.
Left
Left
one is immediate injury.
after injuries.
He went to the government hospital. Subsequently, he went to the bone set.
Then
Keep the X-ray for a little while.
What is the diagnosis here? What fractures are there here?
sir, this coronoid process fracture, sir, with subluxation of
What about radius?
radial head fracture is also there, sir.
What are the radius is there?
Yes, sir. Fracture is there, sir.
Neck fracture, mostly the neck fracture, which got repaired.
The coronoid is big fracture.
Originally, you must have had a classical medial trade of elbow, and probably the bone section must have
Coronoid fracture classical.
reduced it.
Coronoid fracture, sir, Mason, nahi,
What type?
type 4, sir.
Because contact from the base. That's all.
Yes, sir.
It is almost flat with the shaft,
Right.
almost straight line, in straight line.
Regan Moore, sir. Regan Moore. Sir, he is having difficulty in flexion extension.
Very small speck of calcification here and somewhere, okay, very insignificant. The ulnohumeral in the AP view appears to be complete, but in the lateral view there is a subtle subluxation.
Yeah, there is.
With a fairly big coronoid channel.
So how many months old now?
3 weeks, sir.
And here you can see
3 weeks.
3 weeks.
3 weeks.
This is the coronoid fragment. Radial neck fracture might have healed. Yes, next.
So we have done CT scan.
CT, what disclosed CT? Anything extra you got from CT? In fracture surgery?
To know
Yes,
the
sir.
status of the radial head, probably. And for any myositis.
In report they mention, sir, for radial head type 3 and for oligron.
Zoom the radial, yes. The neck fracture is there, it got tilted. But the lateral column is still stabilizing. That is why the elbow is also relatively safe.
But the gap in the joint is seen because of some fragment inside the joint.
There is sagittal cuts, sagittal cuts. Here the fragment appears to be relatively smaller compared to what is seen in the X-ray. And here is the neck fracture. And lateral margin. Most of the articular component of the radial head is intact. Most of the radial head component, articular portion is intact.
But the corner looks big or bigger. I got all observed. Just crossing the head.
Yeah, it's fairly big chunk.
Whenever it comes out. So what's the problem now? Just cover the bone.
Sir, raising
Limitation of movements.
restriction of movements.
8 weeks old,
3 weeks, sir.
3 weeks.
3 weeks. Sir, in report they mentioned type 3 fracture of coronoid process and type 4 fracture of radial head.
So, is it tried or not?
Sir,
What tried is it?
terrible traits.
Name all the 3 components here.
So dislocation of the elbow with radial head fracture and coronoid process fracture.
No, no ligament. Bones are intact.
They must have done. But now, in the, it is almost near anatomical solution. Near. Not exactly anatomic, but near anatomy. Probably the ligaments must be healing. Some
Main thing is,
fibrosis.
main thing only the bony component stored.
Subluxation is there. Coronoid is the one which is causing the error. Otherwise, it's likely to slip away.
So what is diagnosis there clinically?
Sir, clinically, this terrible traits.
Can you
All
diagnose a 3 weeks old terrible fracture?
Stiffness or
Stiffness,
fibrosis of the elbow.
myositis,
Examine this case.
myositis ossificans.
Three bony point relationship is maintained in the position of 80 degrees. The elbow could not be extended fully, and limitation of movement. That's all you can judge clinically.
Stiff elbow
You
or
can't,
arthrophyrosis is there due to some problem.
you cannot make a diagnosis of a terrible triad clinically. You cannot diagnose a coronoid fracture.
Right.
So how to approach?
What did you think? What is the plan for this?
So there are 2 components. One is dislocation has to be reduced.
Yes, sir.
Anatomically, by which approach? And the coronoid has to be fixed.
Yes.
These are the 2 issues. Probably you can
What about radius? Nothing.
radius. I think you can leave it. It's a muscular contour is very well maintained. Neck is tilted a little bit, but that is acceptable. Slightly tilted, that is quite acceptable. Lateral column is intact. So how to approach the coronoid? How to approach the subluxation?
Lateral is just what I do. Lateral approach your job on the lateral side. Go to that side and put a anti-posterior or posterior altogether. The KY or the screws.
For coronoid,
Already there must have been fibrous tissue in
But
between
now,
the.
I don't know, but that's
You have to
big
open
one.
the coronoid.
That's what I will say. Lateral approach can go directly to that area.
But
Two lateral
we
approach.
will not be able to approach the coronoid from the lateral
Why not?
aspect.
Yes, you
More
can.
on the medial side.
Correct, you can open the joint from the lateral side. You can reach that.
so plating for coronoid.
Or subluxation by posterior Campbell's approach and another approach by
Campbell?
for the coronoid.
Campbell approach? No, no. If you get to the coronoid,
Two separate. Unless you clear the fibrous tissue,
I know, but
you will not be able to reduce it.
Generally we go, we can pull the biceps tendon, get the coronoid fixation, do any capsulotomy or capsulolepsis, and then another approach posteriorly. Get the posterior capsule. To get the range of motion. Because pronosupination suggestion is intact, but only flexion extension is not. Flexion extension mostly will be because the anterior capsule is already taken.
that has to be fixed. Just you can't expect only to that fixed.
And post-operative, some degree of limitation of movement
Is expected.
and preferably give indomethacin.
Indomethacin.
3 of. Because we do not
Only
know.
3 months only?
3 weeks.
3 weeks, sir. 3 weeks.
Massage several times. Luckily, the neck fracture.
Now they believe now coronoid is main problem means posterior lateral side. So that's one main problem. Posterior approach is also one. If you want to fix even with radius also, open close. Only coronoid means you can go from that.
Admitted or
Sir, today he will come, sir.
Right.
admit?
Yes.
Good morning, sir.
When you are doing some PPT like that, you should not put sir. Can you go back to the 3 weeks old variable made of massage prevention. 3 weeks old with 10-degree FFD and then 10 degrees to 80 degrees flexion. Pronation, supination, massage several times.
10 degrees to
80.
80. Okay, yeah.
Slide show that. Slide show.
Okay.
Zoom that lateral view. Zoom the lateral view X-ray.
Oh yeah, this one. Now, come to it.
Sagittal.
So describe what is
Previous.
not the 3D. This one. So describe what all.
There's a coronoid fracture, sir.
Okay.
There's a coronoid fracture, radial head, radial neck fracture, and
Neck fracture.
neck fracture. There's a fracture, sir.
Okay.
And there's subluxation of the elbows.
Subluxation of the radial head. Okay.
Yes. Elbow.
Radial head is
Radial head is in place, sir.
Okay.
Elbow
What
is
is the
in
main injury?
coronoid fractures.
Go back. X-ray. Lateral. fairly big chunk of coronoid which is gap, with a gap, with mild subluxation.
Subluxation. But that subluxation probably giving him range of movements. How old is the child? 44.
3 weeks. Age is
44. Painful?
Yes, sir, painful, sir. There's swelling and pain.
3 weeks only.
3 weeks only.
Okay, go.
History of
CT
native
scan again.
techniques. कर सकते तो
first put the sagittal and then corona. 3D కాదు, 3D will not give that much clarity.
You should have done it. Yes. The PPT itself. Take that part only, then present it. Next slide. Yeah. Okay, stay there. So, coronoid, there is a gap there, and there's a subluxation.
Neck is
That's not significant.
it is stable.
Is it unstable because of massage? Maybe may not be.
Massage might have caused the stiffness.
Sridhar,
Sir,
what should we do?
need one coronoid has to be fixed so that we can approach anteriorly to a capsular release, and another, because already it's 1 month old, another approach posterolaterally can use the posterolateral capsule.
Probably this gap is not acceptable.
Yes.
It goes into
And
Compression,
yes.
how much through
and
And
it
it's
makes
articulating with that gap only, so that needs reduction. 3 weeks, I think, is not long. Probably massage might have added, but if it is 3 weeks stiff elbow, then difficult to take. But 3 weeks with the mobile elbow, full supination, pronation means the radial head is not causing any problem. Okay. That's fine. Next. Whenever you're putting CT scan, you should see, unless you know which to present, you won't be able to present everything. So select which are important. And 3D is no good. Don't ask for any 3D reconstruction. When you ask for CT scan, do not ask for 3D reconstruction. Because if software is not good, it will reconstruct, it will mislead you. What we need orthopedic surgeon, see, X-ray we know very well. So CT is a magnification of X-ray. Instead of reading one plane, we are reading different planes. And you should be able to read X-ray, isn't it? Go on.
Good morning, sir. This is a journal for today. This journal is risk factors for unsuccessful reduction of chronic Monteggia fractures in children treated surgically. This is a journal taken from Bone and Joint, July 2024 edition.
Oh, who is the author?
Authors.
That's important. You wrote your name. You should give some credit to the author who has worked very hard to. Chinese. That's why I didn't. Not interested. Chen. Okay, that's fine.
Yes.
Yes, go ahead.
Done.
Introduction.
So bone and joint is open,
Open.
not printed.
No, open access, sir.
Open access.
So Monteggia fractures are rare in children, less than 1% of pediatric fractures, and are often missed at diagnosis, leading to chronic Monteggia fractures when untreated for over 4 weeks. Chronic Monteggia fractures can result in pain, limited motion, and deformity due to the persistent radial head dislocation. Achieving stable radial head reduction is challenging in these cases.
GCP పెట్టలేదా?
La-
Cardinal tibial GCP.
Previous study.
Not written. Right. Okay, go on.
Previous studies, limited by small sample sizes and single factor analysis, have provided inconsistent findings on risk factors like age and time to surgery. Other potential factors such as dislocation distance and ulnar osteotomy level were underexplored. This multicenter retrospective study aims to evaluate surgical outcomes and identify the multiple risk factors for unsuccessful radial head reduction using both single and multivariate analysis, hypothesizing that delayed treatment and other factors contribute to poor outcomes. Methods. A retrospective review was conducted on 312 pediatric patients treated surgically for chronic Monteggia fractures between March 2015 and March 2023 at 6 institutions. Inclusion criteria were diagnosis greater than 4 weeks post-injury, age less than 17 years, complete clinical or radiological data with AP and lateral forearm x-rays, more than 6 months follow-up post-successful radial head reduction. Exclusion criteria, metabolic diseases, osteoporosis, pathological fractures and congenital radial head dislocation, and less than 6 months follow-up were excluded. Surgical treatment. Surgical treatment decisions were based primarily on the surgeon experience and preference and intraoperative stability of the radial head. A total of 174 patients underwent open reduction of the radial head through an anterolateral approach, while the remaining 35 underwent closed reduction of the radial head. Among the patients treated with open reduction, dislocated radial heads were reduced without attempting closed reduction in 78 cases, while in the remaining 96 cases, open reduction was performed after unsuccessful closed reduction of the radial head. All the patients who underwent radial head closed reduction also underwent ulnar osteotomy, and ulnar osteotomy was performed in 157 of 174 patients, that is 75%, who underwent radial head open reduction. Ulnar osteotomy was performed through a posterior ulnar approach or Boyd posterolateral elbow approach. Plates and screws were used to fix the osteotomy site in 74 patients. Monolateral external fixator was used in 77 cases, and KYs were used in the remaining 41 cases. The monolateral external fixator was removed once the ulnar osteotomy site was achieved a radiological union. Additional procedures included annular ligament reconstruction, radiocapitellar joint fixation, and cast immobilization. Annular ligament reconstruction. Annular ligament reconstruction was performed on 146 patients of 174 patients, that is 69% of cases, who underwent open reduction of the radial head with either forearm fascia or triceps fascia circumferentially around the radial neck. Radiocapitellar joint fixation. Radiocapitellar joint fixation was also performed when the radial head did not achieve adequate stability during the surgery. Radiocapitellar joint fixation was achieved by passing a K-wire through the capitulum to the proximal part of the radius via the posterior elbow. Of the 108 elbows with the radiocapitellar junction fixation, 5 underwent radial head closed reduction and 103 underwent radial head open reduction. The K-wire was removed 4 to 5 weeks after the procedure. The cast immobilization. The cast immobilization was used to improve the joint stability. Following the radial head reduction, 168 elbows, that is 80%, were immobilized using a long arm cast for 4 to 6 weeks, while the remaining 41 cases were treated without cast immobilization. Cast immobilization was performed in 12 out of 35 patients treated by closed reduction of radial head, and in 156 of 174 patients treated by open reduction of the radial head. The outcomes of the surgery are immediate radial head reduction was attempted in 91% of the cases, achieved 20 out of 35 by closed reduction and 171 out of 174 by open reduction. In 18 patients, gradual radial head reduction using monolateral external fixation at 1 mm per day was successful in all cases. Among them, 3 required additional annular ligament reconstruction, 2 underwent radiocapitellar junction fixation, and 3 requiring another cast immobilization. The external fixator was removed once the radial head reduction was achieved. Radiological evaluation. The pre-surgery radiographs of the forearm were used to assess the direction of the radial head dislocation, the elevation of the dislocated radial head, the width of the proximal radial metaphysis, and the angulation of the ulna before surgery were used. Post-operative ulnar angulation, the site of ulnar osteotomy, and the quality of radial head reduction were determined using the radiographs taken on the first and second half of the second day following the procedure. All the measurements were conducted via the picture archiving and communication systems. The two pediatric orthopedists independently measured these parameters. Radiological measurements were repeated at 2-week intervals and mean values were used for the statistical analysis. The direction of the radial head dislocation. Due to the inapplicability of the Badow classification in the pediatric chronic Monteggia fractures, the direction of the radial head dislocation was determined by analyzing the preoperative AP and lateral forum radiographs. The observed directions of the radial head dislocation were anterior, anterolateral, anteromedial, lateral, and posterolateral. These are the radiographs showing the radial head dislocation, direction of the radial head dislocation. This is anterolateral radial head dislocation. This is anterior. This is lateral, anteromedial, and posterolateral. Elevation of the dislocated radial head. Elevation RH was measured on the preoperative AP and lateral radiographs. It is measured using the distance between the centers of the dislocated radial head and the capitulum, expressed as ratio of the distance between line passing through the center of the capitulum and that of the proximal radial metaphysis to the narrowest width of the radial neck. A larger ELIV RH shows the dislocated radial head further distant from the anatomical position. Width of the proximal radial metaphysis. According to the previous studies reported by Kim et al., the measurements of the width of the proximal radial metaphysis on the preoperative AP and lateral radiographs were used to calculate WRPM, and it's expressed as the ratio between width of the proximal radial metaphysis and the width of the narrowest part of the radial neck. The larger WPRM reflects the excessive enlargement of the radial head in relation to the radial neck. Ulnar angulation. Lateral radiographs were used to measure the angle between the axis of the proximal and distal parts of the ulna. It is expressed as 0 when the two axes are parallel, negative when the apex of the intersecting axis is inferior, forming an inverted V shape, and positive when it is superior, forming a V shape. The larger absolute ulnar angulation exhibits the more severe deformity in the ulna. These are the lines passing from the proximal and distal ulna, forming angulations. Site of the ulnar osteotomy. The ratio of the length of the proximal ulna to the total length of the ulnar bone was used to express site of the ulnar osteotomy. The larger the site of ulnar osteotomy reflects the osteotomy site more distal to the elbow. Quality of reduction. Anatomical radial head reduction was defined as the radial neck axis passing through the middle third of the capitulum in both the views. Unsuccessful radial head reduction was defined as failure to achieve the anatomical reduction intraoperatively or early postoperative dislocation, except in gradual reduction cases. Redislocation within 2 weeks postoperatively. Redislocation after removal of the external fixation or K-wire. This study identifies the time from the injury to surgery as a sole independent risk factor for unsuccessful radial head reduction in pediatric chronic Monteggia fractures, particularly when the surgery is delayed beyond the 7 weeks. Timely anatomical restoration may improve surgical outcomes, supporting our initial hypothesis. The overall reduction failure rate was 44%, slightly differing from the previous reports. They defined the failure as inability to achieve or maintain anatomical reduction during the surgery and follow-up, offering more accurate insight. Dai et al., who reported a 1.37-fold monthly increase in RHR failure with a surgical delay. Delayed treatment allows for ulnar remodeling, joint space narrowing, and morphological changes in the radial head, all of which hinder the reduction. Anatomical changes at the injury site often occur within 7 weeks, making delayed surgery more challenging. The proximal radial physis is key to radial head development, and the radiocapitellar joint helps limit the overgrowth. Kim et al. Reported radial head enlargement and slender neck within 3 months post-dislocation. Previous studies reported longer cutoff values but used subjective groupings and lacked robust statistical analysis, reducing the reliability. Notably, the study did not find age at the time of surgery to be a risk factor for unsuccessful RHR. Results agree with those of the most previous studies. However, several previous studies reported a significant correlation between age at the time of surgery and reduction failure rates based on the single factor analysis results. The controversy may stem from limited sample size reported in their studies and the lack of multiple regression analysis. The results of multiple regression analysis might refute the results of univariate analysis. In the study conducted by the age at the time of surgery was identified as a potential risk factor for unsuccessful radial head reduction based on univariate analysis, but the conclusions were refuted by multiple regression analysis. However, this study found that both the single and multiple factor analysis failed to identify age at the time of surgery as a risk factor for reduction failure.
See, there are more than 12 lines in this slide.
Just like reading from the journal.
You just have to put key points. That is the journal review.
And you did not read.
Yes, I read, sir.
Read it.
Read it.
Next. They are just keeping quiet because every side is like that. There is no point in criticizing.
Limitations of study: retrospective design with no power analysis, functional outcomes and follow-up of the failed radial head reduction cases not analyzed, short minimum follow-up, small number of patients with non-ossified radial heads may affect some measurements. Despite the limitations, this is the largest study to date systemically assessing the risk factors for unsuccessful radial head reduction in pediatric chronic Monteggia fractures. Further prospective studies with longer follow-up are needed. Conclusion: the study revealed that the time interval between the injury and the surgery constitutes an independent risk factor for unsuccessful radial head reduction in children with chronic Monteggia fractures who undergo surgical treatment. The study also established that the cutoff value for the time from injury to surgery is 7 weeks, which is shorter than the previously reported. This suggests that anatomical changes that make radial head reduction challenging in patients with chronic Monteggia fractures may occur quicker than previously thought. These are the procedures done over the chronic Monteggia fractures, various procedures done.
Not here.
External fixator, sir. Not here, sir, not here.
Next one.
So plate fixation with ulnar osteotomy.
Okay, next one.
External fixations.
You are against passing the
That's all. But that's a retrospective study. We are talking about current study, current treatment. Done?
Done, sir.
Yeah.
So
what do you think?
Waiting case is there.
What?
Today we have posted.
So what do you think? What do you think?
Sir.
What is your conclusion? Not what you are criticism?
3 weeks old.
When the
No, about the article. General club is about the article. What do you think about the article?
they have took the criteria as age as impossible.
What do you think of the article itself? Is it worth reading the article or not?
They have gained some knowledge with this.
See, any journal, any article, it should affect your practice, isn't it? Whether you're going to practice it or not to practice. So what is that message you can get from this?
Radial head reduction is important in the chronic Monteggia fractures.
Okay. And about the article, tell me one good thing and one thing which yes. What?
Risk factors. What are the risk factors you come across?
They have used age and the time duration from the injury to surgery.
Title of your journal is the risk factors.
Yes, sir.
Unsuccessful thing. What are the risk factors for unsuccessful?
They have used age, sir. They have used age and time from the injury to surgery, and
Posted today. 3 weeks old.
Child.
yes, sir.
Yeah, you didn't say. What is that? What is anybody? What is the positive? Why is published? What is the reason they published? Why do you think the paper is published, the study published?
Because if, in the cases which are not treated, there will be a limitation of moments.
You only said, you just read in the conclusion, large number, series, bigger series, that's the only reason they published. And of course their analysis is good. And it's, what is the message? What is the, it's a retrospective study.
Retrospective study.
So what is the disadvantage of retrospective study? You know what is retrospective?
Yes, sir.
What is it?
We go back in the time and cases we.
So we don't see the patients.
We don't see.
We only see the notes.
Yes.
Data. So data, we don't know what data, whatever data is there. And what is the advantage of a prospective study? Pratik is there. Vivek. Pratik. Not there. Vivek. Sushma. Vivek, come on. What is the advantage of a prospective study? Not, you can't do randomization of these patients, but prospective study. What is the biggest advantage of prospective study? So you make a policy and you decide what all data you want to collect.
Yes.
So it is more evidence, in the sense you know what exactly you are looking for, and you make sure those things are looked for. In retrospective data, you don't know what the data is recorded. Most of the data may not be relevant, and most of the data is incomplete.
Yes.
And there is no protocol. There is no protocol. There is no follow-up. What is that? Regime.
So like in the methods you told, if you do a retrospective study, there will always be surgeon preference, interpretive decisions. If you do a prospective, you will know which patient you have to do an osteotomy, and which level you are doing an osteotomy, what cases you are picking, how much duration between injury to intervention, that all can be determined. That is a better study.
But the point that they have stressed more in this
Cutoff point.
is the time duration between the injury and the open direction, and also that is because the ulna gets remodeled in children, unlike in adults. With the remodeling, you do not know where to do the osteotomy, and you may need to put the angulation to reduce the radial head. Don't try to see that the ulna should be straight. It has to be angulated, and where the osteotomy has to be done, he has drawn some angles.
Yes, ulnar angulation. Yes.
So you need not correct the deformity of the ulna because it's already remodeled. So you have to make sure the joint is restored. Yeah.
So in that X-ray also you could say how much grossly they have done the osteotomies just to get the radial head
Position, yes. So much of angulation has to be done. Otherwise you can't reduce the radial head. So don't bother about the angulation which is produced iatrogenically.
This is a case in our hospital, sir, to be operated. Yes, sir. 4 weeks old.
8 years.
4 weeks old chronic Monteggia fracture in a 8-year-old boy, sir.
So when do you want to say chronic? Is there a criteria to say chronic Monteggia or acute Monteggia?
Acute, we immediately we 1 to 2 weeks. 2 weeks.
10 days, right?
Chronic. Chronic, or you say something else?
Untreated, delayed.
Not delayed, untreated.
Untreated. This is a lateral dislocation.
No, neglected. Directly medical legal.
Bone setter did not neglect it. He has done his job.
Yeah. So what do you see here?
There is a lateral lateral displacement of the radial head.
Okay.
Bados classification. Type 3, sir. Type 3. The apex of the fracture is towards the lateral side, and the radial head displacement towards the lateral side. Posterior. Angulation is posterior, sir. Lateral.
It is only the lateral angulation. Intraosseous space is collapsed.
And this looks like more than 3 weeks, you said. 3 weeks. More than 3 weeks.
More than 3 weeks.
Challenge is there.
And the 4th week. The child, the 8 years. APS.
So laterally, you should get a true lateral view one. Second, what radiological parameters they have given in the journal, did you apply that here? What is the elevation of the radial head?
Elevation of the radial head we
That
have,
is
we
for
did not.
bone which has healed and remodeled. Where to now you know where is the fracture. The fracture line has to be osteoclast. That is for
Osteoclasis
remodeled
rather,
bone.
yes.
That is remodeled bone.
This would be easy because there is no deformity, there is no remodeling. So you're planning to do this one.
Yes, sir.
Okay, good.
Ultimately, your aim is to reduce the radial head to the capital line.
So next time, only 4 to 5 bullets, not more than 3 words. You are not, see, you are not looking at us, and they are more, half of them are sleeping. Now, they're thinking something else, what to do next to tonight or yesterday, what they have done. They're not focusing on you. If you look at them, then only they will pay little attention.
Presentation has to be visually appealing. You have to differentiate into flow charts.
It is just copying and pasting.
You can use AI also now.
Nowadays, it's very easy to have a good presentation.
You put this into a ChatGPT, it will give you your PPT.
Yes, put it into, yes, just ask, put some pictures, give some pictures, it will give excellent presentation. Can you put it into ChatGPT and show us next week, just quickly?
I will show. I will show, sir.
The
Anything
problem
else?
is,
No.
they will put the title 1 or 2 days before the Thursday, and they prepare it overnight and then bring it here.
So today we'll decide who is presenting next week.
It has been going on like that, but not being followed.
What you presenting? Did you send? What
Luckily, she didn't put all the charts. There are huge big charts.
In this article, yes. So what you're presenting? Going to present? What is your thesis? So can you do something, study on arthroscopy? Not arthroscopy, but knee injuries, meniscal, ACL, PCL. Find out if there is any review article in OCNA or one of these articles, review article. You know what is meant by review article on meniscal repairs, ACL repairs, PCL repairs, published in 23 and 24. Okay? And send it to Sridhar and send it to us. Put in the group. Okay?
Thank you, sir.
There is one GCP.
Put it done already?
No.
Going to do.
Whatever the journal club you're posting, post it on Monday only so that everybody will read and come.
So put it in the, enter journal, post it in the group so that people will read and they will understand, they will, because reading once will not get into brain. Read it few times, then only you will understand, and then you will be able to ask questions. Next time we will put 4 people in the front. They will moderate. Sushma, you are listening? Your date has not come yet. Probably the date will come.
Can be easily missed on training.
Yeah. Human expenditure.
3 weeks. Almost 3 plus.
Biopsy.
No.
Probably you can save the joint. Yes. Cartilage is intact.
There is a fairly big chunk of cartilage.
Yeah.
Almost full with the microphone.
Nice one this is.
I think there is a particle breach.
మీకున్న 10% ఇంట్రెస్ట్
Particle breach.
ఇక్కడ ఉంది. But even then I think probably can save the ఈరోజు చేస్తాం. Sridhar, you bone, TCAR cuts bone today. Send it to, we have 70, minus 70 degrees freezer.
It requires quite a big amount.
Yeah, you can do it. Bone heads also there, lost the TCAR, THR heads. We'll get plenty. Yeah, we'll take the cartilage out and put conceal. So next time we will put 3-4 of you. So that you know, because this is what you're going to learn. Just read, of course, read basics, but every day changing. You should be able to analyze, criticize what is happening. You know. Nowadays with AI, you can do so many things. Okay, thank you.